ABC Listen. Podcasts, radio, news, music and more.
Norman, are you on social media?
I am.
You are,
Yeah.
which I think would fascinate many. I can't imagine you scrolling at night.
No, I try not to because it's a huge waste of time. And I did abandon Twitter or X because it's such a toxic environment, but Instagram's a bit more friendly.
It is friendly. Gut health is a big topic on there. There are lots of influencers and people talking about gut health.
Yeah, there's one called Priya Alexander, and it's got a big audience.
With reliable evidence-based information.
Oh, really?
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 So influencers are talking a lot about gut health. It's become a very on-trend topic.
But let me not be too surprised by finding out that what they advise is not necessarily reliable.
Yes, and you don't necessarily need to buy lots of supplements or spend lots of money, and it's a very complex topic. There are experts in this space who say we still need more research, and we are going to dive into gut microbiome and irritable bowel syndrome and explore what you actually do need when it comes to irritable bowel syndrome.
And that's just part of what's coming up here on the Health Report. I'm Norman Swan on Gadigal Land.
And I'm Priya Alexander on Wurundjeri Land. Also on the show, iron deficiency is common, especially amongst young women, but we might not be taking it seriously enough. What can you do about it except eat more red meat?
And a story about people who cannot eat red meat, all because of a tick bite. It's an allergy that's slowly being recognised. First, there's something that even exists, and second, there's something that could drive up your risk, perhaps, of heart disease. But let's go to news.
Obsessive compulsive disorder, Norman, this is an extremely complex diagnosis that's often overlooked, but there's some new research in this area when it comes to genes potentially associated with the diagnosis.
Yeah, we should just explain what obsessive compulsive disorder is before we go on. It affects maybe about 1% of the population, so it's not as common as anxiety, depression and so on, maybe about the same rate in the population as schizophrenia. And it's got varying severity. You would have seen a lot of it in your general practice.
I've seen a bit of it. It can be really tricky to pick up because it can often occur with other diagnoses like anxiety or an eating disorder. And often patients, it can take a little bit of time for it to actually emerge, these intrusive, repetitive thoughts, these compulsions that can relieve them for a little bit. But as you said, it can be really quite debilitating for patients and have significant impact on quality of life.
Yeah, and that's when it becomes a disorder, is when it affects your quality of life, that you go back multiple times to check that the stove is off or the door is locked and so on. And we all do that a little bit, but some people do it to the extreme where they really find it hard to help themselves. They know it's not normal behaviour, but they find it very hard to control. Now, the question here over the years has been, what's going on with obsessive compulsive disorder? Is it environmental? How much of it is genetic? What's the cause of the condition? As we want to know what the causes of many mental health conditions. And it's been thought that there's a reasonably strong hereditable element to it. But is that the case? And if that is the case, what might the genes be involved in obsessive compulsive disorder? People might have noticed during the week that there was some publicity given to a new study which suggested that there might be 249 or 250 genes involved here. And I think it's probably worth dissecting that study a little bit so that people understand when these studies come out what they're actually hearing. So what these studies are, and this is a very sophisticated study which takes other studies of obsessive compulsive disorder much further. And I suppose the reason I really want to talk about it is to just a dose of reality into these studies where you hear there might be this treatment coming from this study and so on. But let's just put it in perspective. In order to study genetic variation in a condition that affects only 1% of the population, given the natural variation in our genes between person to person, you've got to study massive numbers of people. And the numbers of people studied in this in terms of cases, in other words, people with obsessive compulsive disorder or people who've had it during their lifetime versus controls, I think there was like 2 million controls and tens of thousands of people with obsessive compulsive disorder. So the first thing about this is the selection of cases. They used 23andMe and other banks of information about genetic information with people with psychiatric problems. And what they're doing is they're not doing gene typing. In other words, they're not doing your genome. What they're doing is they're looking for little markers across your chromosomes called SNPs, single nucleotide polymorphisms. So these are little mutations which they're not mutations that actually affect your life in any way. They're just mutations that are like traffic lights along the genome, which mark places where genes may be. And when you look at millions of these SNPs, these SNPs, then you can get a pattern of genes that might be associated with a condition. So it's called a genome-wide association study, a GWAS. So that's what they did here. Tens of thousands of people, some of whom had been diagnosed by their doctor and some of whom were self-reported. So that's a bit of a problem with
the self-reporting.
So one of the problems with genome-wide association studies is that they don't necessarily, it sounds as if they've found the genes.
Yes.
But in fact, a lot of the time, you're picking up genetic patterns that might only affect 2 or 3% of people with obsessive compulsive disorder. It doesn't necessarily tell you the whole story about everybody with obsessive compulsive disorder. However, boiling it all down, they found about 25 genes that they think could be on the causal pathway. In other words, really related to what's going on in obsessive compulsive disorder. And they were able to study brain tissue as well. So that's good news.
It is good news.
25 genes. You start to find functional things that might be going wrong in the brain where drugs might be able to target it better. So that's where the treatment thing comes in. But you also, and this is where it's really interesting, but also shows you the complexity of mental health issues, there was overlap. So in other words, the genes affecting people with obsessive compulsive disorder also are involved in anxiety, they're involved in depression, they're involved in schizophrenia. And I'm not saying that somebody's got schizophrenia, it's just that the brain dysfunction or the genetic changes that occur in the brain have an overlap to these other conditions. And that's important for doctors and psychologists and psychiatrists because sometimes exactly what you said earlier, Priya, which is it's sometimes difficult to disentangle. You've got somebody with anxiety, you might have somebody with depression, and they've also got obsessive compulsive disorder features. Well, this study suggests an explanation that they could have a common genetic basis and overlap in terms of how the brain is working.
I think, this is very interesting, but how much does this actually change for people who are living with this diagnosis? And the truth is that not a huge amount initially.
I would disagree. We had a story on ADHD and this issue. And what this showed was that if you understood some of this genetic basis, for example, of ADHD, and its association with other problems, you would actually change the way you diagnose and treat kids with ADHD.
Oh, I agree it will help with diagnosis, absolutely. But I think the most important thing here is that when it comes to OCD, there's already a delay in diagnosis for a lot of people. It can take up to 9 years. It can be quite tricky to actually pick out that there might be OCD here. The management can be very unique. So people might need a specific form of cognitive behavioural therapy with a psychologist called exposure therapy. Often if patients are using medication, they need higher doses, like doses in the higher range of these medications called SSRIs, this class of drugs. There are already a lot of nuances and difficulties in this space. And I just mean, Norman, that for people coming into the consulting room tomorrow, this study is very interesting. I agree with you. It's going to help us diagnose people and be more aware, but it's probably not going to change much tomorrow in terms of management.
And the other thing is what they showed was that in this GWAS study, it was associated with lower risk of inflammatory bowel diseases like Crohn's disease. And what this brings up is something we talk a bit about on What's That Rash, which is pleiotropy. This is where genes have more than one effect.
Okay.
So genes that might actually predispose you to OCD, entirely unrelated to that fact, or maybe not entirely unrelated, they may be associated with a reduced risk of inflammatory bowel disease. Anyway, you're not going to bring up pleiotropy tomorrow morning in the surgery.
I'm not. Very interesting. Definitely watch this space. But in other news, there's been an international obesity conference, 2 big papers published this week in the New England Journal of Medicine and Lancet when it comes to obesity and this class of medications called GLP-1s.
Yeah, well, do you want me to take the first one? I'll take the first
Why
one.
not?
You can take the
Go
second
on.
one. People might remember that during COVID, we quoted a lot of data from Israel, and that's because they've got these quite good databases in their health service schemes, and they can go back and track diagnoses, treatment, what people get, and so on. And it was very good for analysing the effects of COVID vaccines. What they've done in this study is they've gone back to look at a very important issue, which is cancer-related obesity. So in other words, obesity is related to the increased incidence of certain cancers, pancreatic cancer, breast cancer, uterine cancer, and so on. Now, it's known that if you have bariatric surgery, that helps to reduce the risk of what's called obesity-related cancer. And what they wanted to know, looking back in time, and this is a problem with the study, but looking back in time, is whether the early versions of the GLP-1 agonists, so that's the Ozempic-like drugs, also in the same way reduce the risk of obesity-related cancers. This was a study of people who were overweight and obese and who had diabetes. So they were being used for diabetes, not for weight loss. And in brief, what they found was that the GLP-1 did not increase the risk of cancer, not that that was expected, but that's a comforting finding, and may in their own right reduce the risk of obesity-related cancer. So go on to the second one now.
Well, can I just add there, because I'm getting excited about this, that the benefit wasn't just related to weight loss alone. It's
Correct.
possible that there may actually be other things here in terms of signalling and inflammatory markers and lots of different things. But that's very interesting. The other one in the New England Journal of Medicine essentially compared two different types of GLP-1s, so tirzepatide, which people in Australia would know as Mounjaro, versus...
Which is in fact two hormones in one. It's not just a GLP-1.
Yes, and semaglutide, which people might know as Ozempic or Wegovy. And what they did is they compared these two medications head-to-head in 751 people who did not have diabetes, but they were living with higher weight, and they assigned them randomly to one of the medications. They used them weekly for 72 weeks. And what they found was that the tirzepatide, or the one we know as Mounjaro, was more effective than the semaglutide or the Ozempic at weight loss at 72 weeks. So people had better reduction in weight and better waist circumference at 72 weeks.
So it's 18 months, and I think it was 20% weight reduction versus about 13 or 14%.
Which is significant because tirzepatide being better, well, it's the most expensive of all.
And just of note, because we're always a bit sceptical on the health report, it was funded by Eli Lilly, which makes tirzepatide, and drug company funded studies usually favour their drug when you look at them overall. But nonetheless, these results did get into the New England Journal of Medicine, so you assume it's received a reasonable peer review.
On Radio National, you're with the Health Report.
Well, now to upset tummies, which people get a lot. I'm actually minimising a problem which for some people can be quite disabling. It's called irritable bowel syndrome.
It is, and it is often dismissed. People can have significant symptoms, tummy pain, bloating, diarrhoea, constipation. The causes of IBS can be very complex. There can be genetic factors. The gut microbiome may be involved as well. And this is a space that I think people are really interested in terms of, well, what are the causes and what can I do about it to improve my quality of life? And I was lucky enough to speak to a leading world expert, Professor Nicholas Talley, who is a gastroenterologist who specialises in IBS.
It's almost certainly multiple causes. It isn't one disease. It's almost certainly several diseases. We lump it together based on the clinical presentation, but in fact, really these are almost certainly a number of different conditions. One factor we know that's very important is infection, and it's probably related to some low-grade inflammation that occurs with this infection that tends to persist. And so that's one very important factor. Another is taking antibiotics. That changes the gut microbiome, the bacteria in the gut, and in fact, that's been strongly linked to the development of IBS. Excess bacteria growing in the small intestine is thought to be a risk factor as well. So that's again a change in the microbiome. And anxiety and stress are also important factors, but not in everybody. And we know that while it's common to have anxiety and stress, that can be due to having the gut symptoms rather than the cause of the gut symptoms.
So you've mentioned gut microbiome. How can people potentially reduce the risk of irritable bowel syndrome and look after the microbiome?
Well, the microbiome depends on lots of factors. Diet is particularly important. Diet shapes the bugs that live in us and help us stay healthy. So eating a healthy diet that's full of fruit and vegetables, full of fiber, simple, sensible dietary advice, that can be really helpful in both preventing and also treating IBS. Exercise shapes the biome as well. So a good exercise program can actually help reduce your risk of developing IBS and other serious gut diseases too. Medications change the microbiome. That can be hard to change those if you need those medications. If you don't need those medications, my suggestion is you don't take them.
And what medications are those? Is that antibiotics or others?
So antibiotics are very bad for the microbiome. Antibiotics change the microbiome acutely, and that can lead to more permanent changes in some cases. So antibiotics, we have to take them sometimes, obviously, but we shouldn't be taking them unless we need the antibiotic for a bacterial infection. Proton pump inhibitors, acid suppression drugs, they also change the microbiome and are thought to potentially be important. But in fact, most drugs we take and most over-the-counter herbal and other products also shape the microbiome.
You mentioned before that for some people, the brain component can be a big part of IBS. And people might have heard of this brain-gut interaction, this term, when we talk about irritable bowel syndrome. Can you just explain what that means?
What it really means is the brain and the gut talk to each other. We know that. The brain and the gut are intimately connected through the nervous system. Bacteria and other organisms can actually influence the signaling coming from the gut to the brain, and the brain can influence the gut directly, particularly through the stress pathway. So if you get stressed and you release cortisol, then you can affect the gut as well. So there's this two-way communication. But what's really interesting is this. We and others have shown that about half of people with IBS, for example, seem to get anxiety or stress-related problems first, and then they develop IBS. It seems like the stress drives the IBS. That's about half the people. But the other half, it's the exact opposite. Their gut goes wrong first, and then they get stress and anxiety as a consequence of the gut being affected. And we think that's probably related to the signaling changes that occur in some cases in the gut itself. It actually changes the brain signaling, and that leads to the anxiety. It's exciting, though, because it also may mean if we can fix the gut,
yes,
we may be able to fix the brain.
What about food then? Because people might have heard of FODMAP and certain dietary interventions that might help with symptoms in IBS. Is that for everybody?
It's not for everybody, but it is an important concept. So there are certain fermentable carbohydrates like wheat products and milk products and other products that when we eat these products, the bacteria in our gut breaks them down, releases gas, and our gut is more sensitive than normal, and so we get symptoms. So that's the FODMAP concept, that these fermentable carbohydrates can be reduced in the diet, and some of those, if we take them away or reduce them significantly, that can lead to real improvement in symptoms. And about half of IBS patients, maybe a bit more sometimes, but about half will respond to a specific low fermentable carbohydrate diet. But what's interesting is this too. Some of these so-called fermentable carbohydrates are also food antigens. They switch on the gut immune system. So wheat is an antigen, it switches on the gut immune system. Nuts are an antigen, switches on the gut immune system. And there's now more evidence that at least some with IBS get their symptoms because their immune system is overly active. It gets switched on, and foods are probably a primary driver. Removing those foods, those food antigens, can improve IBS too. So some people with IBS need to take out fermentable carbohydrates. Some people need to take out food antigens. That seems to be where the evidence is landing. So that's really exciting because that means a lot of people can get benefit from food interventions.
And that's where dietitians can be incredibly helpful. Broadly though, irritable bowel syndrome management, because you've alluded to the fact that for some people it's food, for some people it's brain gut. How is it managed then?
I always reassure my patients there's absolutely no mortality associated with IBS, none whatsoever. You live a normal, full life. That's really important for people to be aware of. But it's also a real disease, real problem, and it needs real treatments. In terms of the current approach, it depends on how severe your symptoms are to some extent. But let's just take you through the normal process. Certainly what I do is I talk about diet first. I think we've changed our views on IBS. It used to be medications always with our first approach, but I think these days diet is really a useful approach. And remembering what you're doing with these diets is trying to find the foods that trigger the symptoms, not every food, but just the foods that trigger the symptoms. And it's very important not to overly restrict foods. That's the other piece of this that can actually be a health problem if you do so. So there's that to deal with as well. I prescribe exercise if possible, because as I've said, exercise shapes the biome. There are medications then for people who are not responding or need immediate treatment, and it depends again on what is the most important set of symptoms for that individual. Is it the pain? Is it the constipation? Is it the bloating that people have? Because those symptoms are all part of IBS, but often it's one or two of those symptoms that are the most important for people. So sorting that out really matters. So that's the kind of approach that I take in practice for IBS.
What about gut hypnotherapy and the psychological strategies for people who've got that strong brain-gut interaction element?
I think if there's a strong brain-gut element, these approaches actually do work. There is randomized controlled trial evidence that cognitive behavioral therapy, gut-directed hypnotherapy, and there are some other approaches as well. For example, diaphragmatic breathing, which is often part of cognitive behavioral therapy. Diaphragmatic breathing can help the bloating sensation that people have. Easy to learn and can be applied easily. And for those interested in diaphragmatic breathing, look on the internet, look on Google. You'll be able to find clear instructions about how to actually do this. It's really pretty easy.
That was Professor Nicholas Talley, who is a Distinguished Laureate Professor at the University of Newcastle and a Senior Staff Specialist at the John Hunter Hospital.
And interestingly, I first met Nick when he was at the Mayo Clinic in the United States, where he did a lot of his fundamental research in this area. And the team leader there was also Australian. And for more on IBS, Tegan Taylor did a segment last year on the risk of disordered eating in IBS treatment. And as Nick pointed out, diet changes aren't for everyone. And we'll have a link to that on our website.
On Radio National, you're with The Health Report. Coming up on the show, we explore iron deficiency, which is very common but often an overlooked or underestimated condition. So there are some people who are at higher risk, and we talk about what you need to consider when it comes to looking for underlying causes and management. But first, Norman, you've got a very interesting condition, alpha-gal.
Yeah. This is a syndrome which was first described actually in Australia and now the studies have been replicated around the world and understanding has gone further. And people would turn up at their doctor saying, every time I eat red meat, I get, going back to your irritable bowel syndrome story, but this is not irritable bowel syndrome. I get serious tummy upsets, I can get diarrhea, abdominal pain, and sometimes people can get what's called anaphylactic shock, where they get a generalized allergic reaction which can interfere with their breathing and you end up in the emergency room. And it's often not recognized and not believed. You go to your doctor and say, every time you got red meat, and they think, well, I've never heard of that. It sounds as if you've got something in your mind rather than in reality. But it's a very real condition which goes under various names: mammalian meat allergy, and alpha-gal syndrome, which goes to the actual molecular problem in this. And the person who first described it, or was one of the first to describe it, is Professor Cheryl Van Noonen of the University of Sydney. And I thought we'd try to get to the bottom of it. But before we get to Cheryl, here's Abby, who had a personal experience of it.
Basically, one evening I had a spaghetti bolognese for dinner. It was half an hour after that, I just experienced extreme stomach pain. It wasn't like anything that I've had before, like a gastro or, from eating the wrong foods. It was really severe. And I just wasn't sure, like, where's that come from? What's actually happened. So it took me about a week from the first incident and then it happening again a few times to make the connection that it was happening after eating meat. And because I'd done a little bit of research on tick bites, I'd seen meat allergy come up. And I remembered that I'd had the tick bite only a few weeks ago. So when I went to see the GP, I was quite clear that I wanted to be tested for alpha-gal. And the GP basically dismissed everything that I came to him for and suggested that, it was probably indigestion. He didn't believe in the allergy. And I really had to push for him to prescribe the test. I went and had the test done and the results came back positive. He was quite apologetic when he rang me because he knew that he had been dismissive. I do think that because most people haven't heard of it, they maybe don't take it seriously.
That was Abby, and certainly a dramatic story. Professor Cheryl Van Nuenen, who I mentioned earlier, is part of the tick-induced allergies research and awareness group, and, as I said, was the first person to associate tick bites with this mammalian meat allergy.
So the association between having tick bites and developing mammalian meat allergy after that we described in 2007. And later my US colleagues found the actual allergen within the mammalian meat. And then it was picked up, and so now it's been described in 36 countries last month.
And you were probably thought to be a nut job when you first came out with it. Nobody believed you.
Well, I didn't discover that for a while.
So what's the story? What's the typical story?
It divides into two. People would either have what we call a systemic allergic reaction, and because of the way that the meat is digested, it takes a while for this to happen. So it's all a bit of a surprise when people have their steak with a nice glass of wine about 7 p.m. and then they wake about midnight or 2 a.m. and they're itchy all over. They get up, they try to get to the bathroom because they feel as though they're going to evacuate both ends, and they collapse, and the ambulance comes and our wonderful paramedics resuscitate them, and then we investigate them.
And presumably, when they're seen in the emergency department, the link between the meat eating and the collapse is not often made.
It can take a while, and one of the problems is that of people who have an anaphylaxis, we find that only a small proportion are referred to an immunologist or allergist from some emergency departments. And moreover, we find that of those people who are, not all of them turn up. So people have often had recurrences before we see them.
And what's the second form?
The second form's gut. What happens there is that people have their meat or their mammalian products. Sometimes it's a soft cheese, for example. Feta's very good at doing this, or goat's cheese. And then what happens is about an hour to 2 hours afterwards, they have this enormous problem with nausea and abdominal cramps to the extent that men relate to women pushing babies out.
And again, a bit of a mystery and often a delay in diagnosis because it's not recognised.
Yes, it can be, but a lot of people are very good at this happens a few times and then they put it together because they're not burdened with what should happen. They don't have an idea that you can't be allergic to red meat, for example.
Is it any tick? Is there a specific species of tick that causes this?
Well, in Australia, we have 97% of bites from ticks on this side of the continent are caused by Ixodes holocyclus, the Australian paralysis tick is its common name. We have another tick in Western Australia, another Ixodes species, which can cause it. And around the world, there are probably about 16 different species of ticks that have been involved in generating alpha-gal specific IgE and the mammalian meat allergy in patients.
So what's the process then?
See, years ago, most of the ticks would be on foxes. And then we, in 2003, start fox baiting. The foxes disappear, so the tick has to seek a new host. And when it is on that new host will have a different biome that tick has to defend itself again. So the tick makes alpha-gal, this glycan, a carbohydrate, a sugar, and it coats any protein which is foreign so that it's easily recognised by the immune system. And then the tick, as my Swedish colleagues have shown, have the alpha-gal in its gut and saliva. So the tick bites you. She's embedded just beneath where the meet and greet cells of the immune system are. And so she's bypassed being processed by the immune system. She sets up her blood lake where she's trying to make her 2,500 to 3,000 babies under your skin. And when the tick embeds and squirts, then that saliva will go into the human. And because it's beneath where the meet and greet cells are, then the immune system is forced to make an immune response to this new substance. And then 50% of the time after 2 tick bites, you make allergy antibody to the alpha-gal as well. And then when you eat the meat, well, the alpha-gal is in the meat.
So alpha-gal is foreign to humans.
Yes.
And what's the treatment?
So tick bites cause it. If you don't have any further tick bite, you'll have a rapid reduction in your level of alpha-gal specific IgE within 6 months.
That's the antibody that's produced against the alpha-gal.
Exactly. And so that level will go down. And then what will happen then is that about 3 to 4 years later, if you've got a very high level, then you'll be able to eat meat again. But this is complicated now by the fact that we've found that having alpha-gal specific IgE, even at a low level, is very likely increasing the burden of coronary artery disease.
So you think it's more than the cholesterol? There may be people who have low levels of alpha-gal syndrome or alpha-gal antibodies, and that they may be adding to the inflammation.
That is what is believed.
So apart from avoiding ticks, avoiding meat and hoping that the alpha-gal levels go down, but what you're saying is here's a warning that you might have low levels without knowing it, are there ways to reduce the levels of these IgE alpha-gal antibodies?
Not yet. So it may well be that when we develop a treatment for alpha-gal mammalian meat allergy, then we also may be developing a treatment for coronary artery disease.
Cheryl Van Noonen, who's clinical professor at both the University of Sydney and Macquarie University.
On Radio National, you're with the Health Report.
Priya, people associate iron deficiency with anemia, in other words, your haemoglobin drops. But in fact, the point of this story is iron deficiency is a condition in itself independent of what your haemoglobin is, the substance in your blood that carries oxygen.
That's absolutely correct. So you can have iron deficiency and normal haemoglobin, no anemia, and still have symptoms like fatigue, problems with concentration. Some people might have that drop in their haemoglobin and the anemia, but even if you don't, this can be a serious problem. We need to investigate the underlying causes, and it can cause symptoms that require management.
And in terms of treatment, it probably is under-treated. And one of the treatments is an intravenous infusion, which is not straightforward because it can cost you money.
Yes. So iron infusions don't actually attract an MBS rebate. So the federal government doesn't subsidise the cost for patients who need it. And if you walk off the street, Norman, and come into my clinic and you need an iron infusion, it can cost you $200 or more. It's significant and it's not subsidised. So the RACGP, the College of GPs, has proposed a $200 item number to help patients access this care. It's not so far been approved, but they have said it could save the federal government up to $124 million a year with faster treatment and productivity, and yet it's still not rebated. So often the people who need it most, young menstruating women, can really struggle to access the therapy they need because it's so expensive.
But we need to put this into perspective. Who did you talk to?
I spoke to Professor Judith Trotman, who is a haematologist at Concord Hospital in Sydney, who is an expert in this space.
Well, the only way you can ultimately fix the iron deficiency is if you identify the underlying cause. And often it's very obvious. I mean, most of the time, the majority of people who present with symptoms of iron deficiency are young women who either have heavy menstruation, which requires gynecological input, or who have had pregnancy, multiple pregnancies, twin pregnancies, breastfed their children, and are chronically iron deficient. In particular, women who have a vegetarian lifestyle.
Who else is at risk, though? Because there are other potential causes of iron deficiency.
Absolutely. Look, a minority of patients with iron deficiency have gastrointestinal blood loss. And there are many, many different causes, whether it be peptic ulcer disease or gastritis or inflammatory bowel disease, polyps, a few of which can be cancerous. And often in the elderly patients, you'll see a bit of what we call angiodysplasia, sort of leaky blood vessels on the surface of the bowel causing blood loss. We as haematologists don't see those patients. The gastroenterologists see them. Where we see the iron deficiency is where patients and GPs have really struggled to deal with the heavy blood loss often associated with menstruation in young women.
What are the kind of management options there?
So the management option, if you can get someone to eat a little bit more red meat, that's a lovely natural way of increasing the iron intake. Not many of us are willing to eat the liver that our grandmothers would have cooked for us previously. But if you can increase your intake 2 or 3 times a week, that would be great, because that heme iron from animal source is much better absorbed than the non-heme iron from plant-based sources. So for people who are vegetarian or are not willing to eat red meat, they do need to go and start taking an oral iron supplement and not take a multivite. Most multivite supplements don't actually have enough elemental iron. You need an iron supplement, and there are dozens of them out there that just provide the iron with or without vitamin C. The trap, though, is that often people will start taking that oral iron supplement and then they get side effects. They might get constipation or tummy aches or even diarrhea, and so they stop. Whereas if they were to take it every second day, they will actually absorb more iron but have fewer side effects.
Does oral iron work for everybody, increasing in the diet or taking an oral supplement?
No, it doesn't. Some people don't tolerate oral iron very well, but there are also some people who don't seem to absorb oral iron very efficiently. And that might be vegetarians who have a high phytate or caltrate diet, which suppresses the absorption of iron. We're all very familiar with the tannins in tea and coffee that suppress iron absorption. Patients who've had gastric surgery, patients with celiac disease, obviously patients with inflammatory bowel disease. There are many patients who don't actually absorb oral iron very well.
What about iron infusions then? Where do they fit in?
Well, they fit in for patients who have anemia, and in particular those who have anemia in the face of ongoing iron demands, whether it be blood loss, whether it be second or third trimester of pregnancy, breastfeeding. That's where you really do need fast, safe, total dose iron replacement. And it's really important when someone's profoundly iron deficient. They might need more than just 1 gram of intravenous iron. They may need a couple of infusions. You see, the other thing is everyone's scared of overdoing the iron infusion. But I don't mind if someone's ferritin gets 300 or 400 for a month or so. It's important that we replace not just the iron to make the red blood cells and get their hemoglobin, their oxygen carrying capacity of the red cells, up to a normal level. We need to replenish their iron stores, what we call the ferritin, and I call it the iron in the tin, the reserves of iron that we have in our liver that help us deal with these times of higher stress. And so often people will receive one infusion of iron, and then the GP will have a look and see, the ferritin is normal, they're fine. But repeat it again a few months later and they will be low because you haven't sufficiently replenished the iron stores. So it's very important to map what happens in the months after an iron infusion.
And you just mentioned there that it's for people who have got anemia, so a drop in their hemoglobin. But in some people who've got iron deficiency with a normal hemoglobin, where they've got lots of fatigue and other symptoms and maybe not tolerating the oral stuff because of the side effects you mentioned, an iron infusion is a possibility?
It's an excellent solution for these people. And it's really important to validate these people's symptoms, because it is well recognised that patients with iron deficiency, even in the absence of anemia, do have fatigue, impaired concentration, reduced work performance, reduced sports performance. Goodness, what we could do for the well-being and performance of Australia if we fixed the iron deficiency that's so prevalent in young women in particular.
That was Professor Judith Trotman, who is a haematologist at the Concord Hospital in Sydney.
On Radio National, you're with the Health Report. So what's in our mailbag this week?
We've had a very interesting email from Dr. Mohammed Adam, who's an anaesthetist in Egypt, a very regular listener of the Health Report. Wrote some nice things to us, Norman, which we'll take, but was talking about the story on same arm booster doses that we did a couple of weeks ago with Professor Trefan.
And just to talk about that story, which you covered, if you got the booster in the same arm, you got an enhanced immune response.
And so Mohammed has actually looked at other literature and raised the question of actually, is it better to get your booster dose in a different arm? So he's referenced some other studies from the US suggesting that if you get it in the opposite arm, you might actually get a stronger antibody or immune response in the longer term. And I actually quite like Mohammed's synopsis here, which is giving the booster dose in the same arm gives your immune system a bit of a head start because you've got that school of cells with what Professor Trefan was talking about. But if you switch to the opposite arm, perhaps you get a more broader response because you've got more schools being generated across the body. And so I guess the question is, which arm after all of that?
So look, you could just spin the patient and throw a dart.
Well, you keep saying throwing darts. I've given so many flu vaccines recently, and I promise you, friends, it's more than throwing darts. Promise.
So have you changed your practice? Is it the same arm at the moment?
I've had a couple of patients ask me because they listened to that health report and they've all said, can you put it in the same arm, Priya? Which is, I tend to do it in non-dominant anyway.
But, Mohammed's done the research. If you have it in the opposite arm, you're going to end up okay in the end.
Yes, it will all be fine in the end anyway.
We love your questions. Send them to
healthreport@abc.net.au.
And in our sister podcast, What's That Rash?, we answer the question, can consuming dairy really give you acne?
Hope not.
So we'll see you next week. Priya, you're going to be away. We'll have Olivia Willis back, but I'll see you in a couple of weeks' time.
Sounds good. I'll come back with plenty of stories. See you then.
You've been listening to an ABC podcast. Discover more great ABC podcasts, live radio and exclusives on the ABC Listen app.